We have our next speaker, Dr. Anand Rao. We will have to bear with one more hour of hunger. So 2 o'clock is our lunch, and I'm glad that Anand could come at a time when he will join us for lunch too. Hi, sir. If you can take that mic. So Anand is a last minute replacement for Dr. Brian Pinto. I requested him, I think, day before yesterday, and I have not had the time. इनका mic on कर देंगे? I have not had the time to formally acquire his CV or introduction.
Hello.
So Anand, 2 or 3 personal questions first of all.
Yeah.
Where have you graduated from and postgraduate?
MBBS, first of all, good afternoon everybody, and it's a pleasure to stand to next multi-talented, multi-versatile Tushar bhai. I'm his big fan. I'm his huge fan, and we always look upon him. I did my MBBS MD from Karnataka, Gulbarga, and did my cardiology DNB under Dr. M.J. Gandhi in Nanavati Hospital. Then I went to London, Southampton. I did my complex intervention training over there. And 2002 onwards, 2004 onwards, I'm practicing. I'm attached to Lilavati, Kharinduja, Holy Family, and Raheja, Bridge Candy. And occasionally I come to Criticare also.
Oh, you have a family of how many people?
Sorry?
Your family consists of?
Wife and 2 daughters.
Okay.
And the older one right now is looking for a seat in engineering. She refuses medicine. She saw us running around, doctor being thrashed everywhere. She said, no way, I'm going to be a doctor. Plus, I think these kids don't have an aptitude of reading for lifelong. I tell them, once you become a doctor, it's a lifelong reading. I remember my teacher, Dr. M.J. Gandhi, telling that you are a student forever once you become this thing.
Like
so,
all of them.
like all of this. See, I learned so many. Tejas was talking such interesting thing. I was sitting there behind and listening to him. I mean, amazing talent and all those things. So we are all learning. So I remember one more thing Dr. M.J. Gandhi used to tell me: the day you stop reading, you start aging. So that's the biggest thing. And he had a big board outside his consulting. The day you stop reading, you start aging.
Wow.
So the reading keeps them younger. That's why all these guys are M.J. Gandhi. I mean, he died unfortunately, but Palajani and all those people are still
Legends,
going so strong.
Yeah,
83, 84.
And your passion is music? What is
My
your
passion is, if I was not a cardiologist, I think a cardiologist I became by mistake. My primary interest is Hindustani classical music. And well, now, yesterday I went and applied at NIMS for BA in music. But yeah, they refused me. They said 52 years you can't come, 35 is the university limit. So I'm now started to learn music from vocal music. Let me see where it goes.
Guru, yeah.
I want to pursue my passion.
Wow. Yeah. Okay, Anand, as you know, today we are discussing invasive diagnostics and interventional therapeutics as the theme of the conference. Of course, you are an interventional cardiologist. So, I will be playing a true or false game with them. And you will have to then rectify whatever mistakes we make. So, first of all, everybody please stand up. Okay, only 4 or 5 questions first. And if my statement is true, they will turn to the right. If my statement is false, you will turn to your left. And those who are incorrect in their answers will sit down and the rest will stay standing. Okay? These are all related to, of course, our subject that Dr. Anand is going to do. Your first question is, diabetics with triple vessel disease should preferentially undergo CABG and not multi-vessel angioplasty. True or false? You agree with them? You agree with them? So, it is true. You can straighten again. Asymptomatic patients with a 90% mid-LED stenosis with no demonstrable ischemia must be undergoing an angioplasty, 90% mid-LAD, asymptomatic, must undergo angioplasty, true or false?
It's a mixed response.
What do you say?
I think, we should demonstrate ischemia first and then we should do it. Now we got FFR and all those things, so we have to
all
demonstrate.
those who turn to the right, please sit down. No demonstrable ischemia, asymptomatic, we may not operate. Is that, we may not do an angioplasty, is that right? Okay. Okay, next. Left main coronary artery disease, symptomatic. There is no role for angioplasty and it must undergo CABG. True or false? Left main critical disease with symptoms must undergo bypass surgery and should not under any circumstance be angioplastied. True or false? No role for angioplasty. True or false?
False.
He's an angioplasty guy. Come on.
I got data. I'll present you data.
It is false. Those who turned right can sit down. You have certain situations where the left main can undergo an angioplasty. Correct. In patients with angina or an angina equivalent and an intermediate stenosis, intermediate is defined as 40 to 70%, for example, stenosis. An FFR or fractional flow reserve is recommended to determine whether it is worthwhile to do an angioplasty even though the lesion is intermediate. Yeah? Okay, this is a statement of fact. A high FFR means that angioplasty is necessary. True or false? Numerically high FFR means that an angioplasty is necessary. True or false? Yeah, all of them got that right.
False,
yeah. Yeah, it is right. So all of you stay where you are. Okay. Do you believe in FFR? Do you believe? You do,
yeah.
Okay, there are some cardiologists who have
No,
written against FFR.
No.
So I'm just
FFR is a
wondering.
must. No question.
Okay. Dual antiplatelet therapy post stent, any stent, medicated stent, is necessary for at least 1 year in every situation. True or false? 1 year, 100% in every situation. True or false? My answer was false. 1 year mandatory, because there are some studies of less. But what is your answer?
Guidelines is 1 year. 1 year is
1
mandatory.
year mandatory. So all those who said false, you can sit down, and those who said, those who turn to the right, keep standing, please. Dual antiplatelet therapy, initially, if there is a PiE, for example, is with ticagrelor and aspirin. The dose of aspirin is 150 milligrams and ticagrelor is 90 milligram BD. True or false? True or false? Ticagrelor 90 BD, aspirin 150 OD. True or false? Sir?
Aspirin 75 OD.
So true is wrong, false is correct. Aspirin cannot be more than 75 milligrams if ticagrelor is on. Correct. And 3 people standing, I'll ask them 1 or 2 more questions till I have last man standing, last person standing. In primary angioplasty, PiE, when ticagrelor is loaded by us, for example, in the OPD, you are sending a patient for PiE and we want to load the patient, we will give 180 milligram ticagrelor with 75 milligram aspirin. True or false? That is our loading dose. 75 aspirin and 180 ticagrelor. True or false? They all said false. What do you say?
Aspirin should be 350 milligrams, the complete full dose of aspirin.
So false is the correct answer. All 3 of them got it correct. You have to give a full dose of aspirin as a loading and then convert it into 75 milligrams. I'm out of questions, but I'll ask 1 or 2 more. The commonest, the most disturbing side effect of ticagrelor obviously is bleeding. Another side effect of ticagrelor is exertional chest pain. True or false? Exertional chest pain which may mimic angina. True or false? Exertional chest pain due to ticagrelor. True or false? Turn one side, they have turned right, you can turn left. No idea, okay.
False.
False. It is exertional breathlessness and
Exertional
not
dyspnea.
exertional chest pain. We'll give it to the fence sitter there. सर वो एक वहाँ लिखा है fearless. दीपक भाई, you can please accept this. आप thank you sir. Okay. So this is just थोड़ा सा time pass किया. अभी we will go ahead with the regular talk. Okay. So first of all, one confusing area for all of us is when the patient comes to us with an angiography report and tells us कि डॉक्टर ने angioplasty बोला है, हमको समझ में नहीं आ रहा है, and we are confused by the data because we hear that unnecessary angioplasties are very common and therefore we should know when to correctly advise an angioplasty in an elective situation. So first we'll discuss that area, then we'll discuss the PAMI area
Subsets.
where it is absolutely necessary. So tell us the indications, elective PCI or percutaneous intervention, elective. When will you do a stenting or angioplasty with stent?
So, first and foremost thing is you go by the symptoms of the patient. I always tell them, we are treating the patient, not the numerical value what we are giving over here. So, once we have a symptomatic patient, he can be symptomatic because of 70% lesion and he can be symptomatic because of 90% lesion also. So, anything below 70%, of course, FFR is the kind of now standard thing available. So, 70% onwards is considered as severe stenosis. It can be either low severe, moderate severe and very severe. So 70 to 90% or 100% is what is the situation where we advise for angioplasty in an elective case. But in an emergency case, of course, we know that patient has come with unstable angina, troponins are elevated, and he's got these ECG changes. Many a times in unstable angina, you do have a normal ECG. So we take a help of echo. If the echo is showing new wall motion abnormalities, then we go ahead and treat that artery. But if these arteries are like 50, 60%, I think at that time we should not do anything. We should sit tight on it. Maybe after 48 hours we do a FFR, then really understand it. Because in acute situation, the FFRs are not reliable. So there is a confusing area in both the situation. But as a general practitioner, when you get a report which says 80-90% everywhere, I think it's pretty much an indication for either stenting or bypass surgery for sure.
Okay, so you said symptomatic more than 70% lesions.
Yes.
You should intervene either with a bypass or an angioplasty.
Absolutely.
And proximal LAD single vessel disease found on, say, after a positive stress test. Patient otherwise asymptomatic, stress test positive, you go ahead with an angiography and 90% LAD lesion, proximal. Is there any controversy in that area or you have to do the...
So, LAD supplies almost 50% of the heart. It's the biggest vessel and we call it as a lifeline. Even the surgeons, when they graft lima to LAD, that's the primary motive actually. So a proximal LAD 90% stenosis, which is called as a widowmaker lesion. This is called as a widowmaker lesion. So this has to be addressed, no question. And you are given a very profound evidence saying that this stress test is positive. So if stress test positive 90% proximal LAD has to be done without any question.
So as you said, it's a widowmaker. Widower maker nahi,
Widowmaker.
खाली मर्द मरते हैं क्या? Okay. Okay. So this is a very clear situation where we have tight lesion, important vessel with evidence of ischemia. Now the problem is when there is no evidence of ischemia, now is the problem. Same lesion, 90% proximal LAD, you do a thallium stress test and normal. Thallium scan and normal.
Yeah.
What do you do?
So this is a typical question. Now we don't have stress test is not done. Now he's come with a regular health checkup. Calcium score was very high maybe. And then we did an angiography. Somebody did an angiography and found a 80% proximal LAD lesion. So earlier, this kind of lesions, we used to think a lot. We used to repeat a stress test and all that. But now, since you're in the cath lab, it takes hardly 5 minutes to put an FFR wire over there. These are physiological studies. FFR, RFR, IFR, these are all physiological studies. What they do is basically, you produce a hyperemia. Hyperemia is increased blood flow in that area. So the proximal and distal to the stenosis, the ratio is calculated once you produce hyperemia by giving adenosine or various other medication. You do an FFR. FFR less than 0.75 has to be stented. There's no question about it. There's a clear data now. FFR more than 0.75 or 75 to 0.80 is a borderline. But if it's more than 0.8, you don't have any rights to intervene this patient, keep him on medical therapy. So you are in the cath lab, you don't have to think about thallium, MRI, dobutamine stress echo and all those things. Now it's very clear, do a physiological study. If you don't have a FFR in your lab, then you're in trouble. So probably you can reschedule next day and then do an FFR. Yes or no answer. Either yes or no, nothing else.
So what is the equipment needed? Why is FFR not in every cath lab?
So basically it's like a wire. It's a wire which has got a transducer at the tip. There's a transducer. So you pass the wire beyond the lesion and you keep it there and it is connected to a console. The console will show the graphs. And once you do hyperemia by giving adenosine and all those things, you give it for 2 minutes. Adenosine is given for 2 minutes with the big bore vein, either brachial or central line. And in 2 minutes, you see the gradient being separated and the ratio is calculated. It's a real time. It comes real time. And once it comes, then you know whether to intervene or not. These consoles are not available in all the hospitals. And FFR itself, the wire itself costs 50,000 rupees. So 50,000 is the wire, plus you need to have a console. So plus additional hospital charge. So approximately 70,000 costs FFR. So not many hospitals are equipped with this. Even if the company fellow gets the console, of course console, nobody buys the console, they get it case-wise, but patient should be able to give at least that 60, 70,000 rupees for the wire. Which I think is not a big deal because he will get a stent or not get a stent. I think it's a great this thing because after FFR there are no questions asked. Either you do it or don't do it. There's no further test required after that.
So those who have seen the video of FFR that we have posted, they will know. But I'll just give you the very basic and he can rectify me. Fractional flow reserve is a measurement of the decrease in blood flow across the narrowing. So if the pressure distal to the lesion is significantly lower than the pressure of blood before the narrowing, the ratio therefore becomes low. And if the ratio is less than 0.75, you know that the blood flow reaching the distal to the artery, distal to the lesion is less, and therefore the artery needs. So it is a kind of measure of ischemia, like it can replace your thallium scan or your treadmill test or the dobutamine stress echo can be replaced by doing an FFR in a lesion like this. And also another important point that I think they should know is when they say 70% lesion on an angiography which is being seen, it's what we call eyeballing. Eyeballing means they see the lesion, and there are of course objective measurements of the tightness of the lesion, but none of the measurements are perfect. Is that right?
Correct. Correct.
For example, something that is seen as 99% may not be 99%, maybe less.
Yeah.
Is that right?
Yeah.
Usually we overestimate.
The more tighter the lesion, your estimation is good. But as you said, the 70%, in some angle it may be 70, in some other angle it may be 50 or 60. The lesion is, sometimes the lesions are very eccentric. So in a caudal view, it may be 70, 75, but you go to the cranial view, it may be only 50%. So these are the lesions.
So would you do an FFR in borderline or intermediate lesions?
Absolutely, absolutely. So these are the lesions, intermediate lesions, where FFR is useful because putting a stent is not a big deal. I think we have matured enough. Now the teaching is when not to do a stenting. Everybody knows when to put a stent. Now the learning is like in stress test, our teachers taught us when not to do a stress test on this patient. It's very important because we have lost patients on the treadmill. So now when not to do a stenting. So this another one thing I want to add to Tushar Bhai's this thing is, now for example, there's a triple vessel disease. This is very important, you have to hear it. There's triple vessel disease, there's LAD 70%, circumflex 80-90, RC is 80-90, there's some additional thing. Now first thing is, you think about bypass surgery. Now again you are not sure, bypass is a big surgery because the LAD flow, in the native LAD flow is so strong, the native circulation is so strong, the Lima circulation will not be as strong as the LAD. So the LAD has to be more than 80-90% for it to be stented or for it to be grafted. So what I do in these patients, I do a simple FFR to LAD, and if the LAD is negative, I tell the patient you don't need bypass, just put 2 stents and go. So you avoid bypass surgery, you put stents in circumflex and RCA, LAD you leave it on medical therapy. So you give surgeon also which has to be grafted or which has not to be grafted. So if the LAD is normal, generally bypass surgery is not advised. So then it becomes simple to explain to the patient also. So the multi-vessel disease becomes single or double vessel disease. This is the advantage of FFR.
So in triple vessel disease, all lesions 70% or so.
You do FFR everywhere.
Would you do everywhere FFR?
Everywhere FFR. If it's negative, medical therapy. If it's
the
positive,
cost of the FFR will be the same as one FFR?
One wire. One wire goes everywhere. No, one after one.
So you do the plasties only in those vessels which are low FFR?
Absolutely.
You can do that?
Yes. So you can avoid stenting, you can avoid bypass surgery.
So often,
that the only fallacy is between 0.75 to 0.8. So if it is below 0.75, so there are trials which have taken 0.8 as standard and 0.75 standard. Many trials have done this thing. So in between those things, you either take the help of ECG, echo or symptoms and try to correlate, which I think is not a big deal, sir. It's not a big deal. So you are putting a wire. One is patient now, if is adenosine sensitive. So now there's a new thing called as RFR. RFR is resting flow indices. Here FFR is you are giving hyperemia by giving adenosine. Here the computer takes the resting flow indices. You don't have to give adenosine. Now adenosine is gone. US made a big hue and cry because the insurance company has to pay for additional adenosine. So first of all the wire, the adenosine, so everything counts in the US. So they came with RFR. Now RFR nothing. You just put the wire, give nitroglycerin to dilate the vessel properly, and the machine will do the needful. So no need of adenosine also now. Same RFR, FFR is the same wire.
The console will be required. The console and the wire will be required.
Console is expensive, but that
Dobutamine will be eliminated.
Yeah.
What is IFR?
IFR is intermediate flow reserve. That is again one of the modifications. We don't have much idea. We don't have it over here. Now the latest one is CT-FFR. So you don't even have to do an angio. You can send them to a CT. The CT does reconstruction of the vessel. It calculates the FFR, which is rough, but it's coming. It's reaching there.
Wow. Okay. Another area, since you are on CT, is nowadays many people undergo a coronary CT scan, not just a calcium score, but even a coronary CT angio, and as a part of kind of risk factor hai to kar diya, and they come to you with say lesions. Such a patient, first of all, may not have done a CT. Now he's come with lesions to you.
He's come with the report.
Come with a report no symptoms, and the report shows say 80% LAD. How do you tell the patient that you should not have done? If you had not done, I would not go ahead with anything. Right. So how do you recommend scientifically such a patient?
So this is a tough area because now CT angio has been included part of the health checkup. Some of the hospitals, I think HN or some hospital, CT angio has been included now as part of the health checkup. So you will get more and more of these patients coming. So first and foremost about CT angio is the person who is interpreting the report. There's lot of variation. So the interpretation, I have sat with the CT people, the artifact, the movement of the heart, especially circumflex and all that, which are posterior, it's very difficult to make out the lesion. And so that. Second is a machine. Of course, machine is all standard in Bombay now. So if the CT angio comes to you with these lesions, the negative CT is 100% perfect. But a positive CT, it depends on various factors. For example, if they say calcified in 50%, that's a bomb. Means in the calcification, the CT rays cannot penetrate. So we really don't know whether it's 50 or 80%. So there are many, many fallacies. I think you have to, as I say, first and foremost is ask the patient, why did you do this and what is the symptoms? If there are symptoms, then you got a big evidence under you. Then you will know these are the lesions. So if you think he's diabetic, he's comorbid, calcium score more than 300-400, and these lesions are there, I would definitely subject him for angio and then take it further from there.
A proper catheter angiography.
Catheter angiography, yes.
Okay. Staying on CT scan, some patients will do a CT scan, CT angio, and will show 30% plaques, 40% plaques. And from what we learn is that the 30% plaque is not a benign plaque. It can rupture and cause an infarction. Correct? You don't have to have a 99% lesion to become threatening. So if a patient comes to you with asymptomatic and has plaques, do you give this patient, even if they don't have diabetes or high LDL cholesterol, do you give them statins like you would give any atherosclerotic cardiovascular disease?
No.
Do you give them aspirin? What do you do?
So you kind of go ahead with the ASCVD risk score. You calculate the AS. For example, 40-year-old person, no risk factors, and he's a pilot. So he has some stress test intermediate, some results. So he went to CT angio. He got this 30-40%. But if you look at his 10 years risk score, it's more than 7.5%. So if the 10-year risk score is more than 7.5%, there is no role of any atorvastatin or aspirin or anything like that. If the risk score is less than 7.5 in the next 10 years, so if you Google the ASCVD risk score, which I think you should have it in it's available, just Google it, ASCVD risk score, there are 7 questions. You add those 7 questions, and then it will give you the next 10 years risk score. More than 7.5, don't do anything. Less than 7.5, start therapy.
Okay.
So the more the risk...
the greater the risk, the more the need for statin.
Yeah. But again, you have to understand when the risk, for example, the same individual, what Tushar is saying, same individual comes with 30-40% lesions. Now you see the LDL more than 140, 150, let's say 150. Now what do you do? No, 150 I will not keep quiet. 150 is not suitable, it's not allowed. That too has got a plaque. For this patient, with consoling the side effects of statin, sitting with him, talking for 15 minutes, I will put statin because he'll be in a denial to take a statin. So console and tell him, this is the situation, I want your LDL less than 100 because you got 30-40% plaque. So what's happening is every treatment is now tailor-made. It's individualized, tailor-made, symptomatic driven and physiological studies driven. So no more, I will say 70, one senior will say, no, Anand, this is 90, I'm a senior, go ahead and stent it. No, it's not allowed. All those things are gone now.
So a lot of family physicians are confused about when to give aspirin and when to give statins. As you know, primary prophylaxis aspirin has been debunked. Many people were giving everybody. Then they said nobody should take primary prophylaxis. Even if you are diabetic, you should not take aspirin. Then now there are studies which say, okay, between the age bracket of 50 and 59, if so and so things are there, you give primary prophylaxis aspirin. So aspirin remains an area of extreme confusion, compounded by the fact that the risk score that we have from the Western countries, the risk score are limited in their capacity. For example, what is more important as a risk according to you, hypertension or strong family history? What? Family history is hypertension. What do you think?
Strong family history.
Strong family. Now, is strong family history a part of any score? Is there any score which says first degree relative less than 55 years of age has had an atherosclerotic event? Is it part of any score? It is not. So that is where his statement comes in. He said you have to individualize therapy. Yeah. So many things we will have to, as prophylaxis, individualize. Statins especially, we will have to individualize. Though we know that 180 absolute LDL is a criterion for starting statin in an otherwise normal patient. If it is 150 and the patient has a father who died at 45 of an acute infarct, I don't know what we should do. We don't have evidence.
Yeah.
But you would start.
Yeah, because the corroborative evidences are important in this kind of borderline levels, you know. So any sudden death in the family, anybody, this thing. So 150 is still considered as harmful to him.
So all of us will have to individualize prophylactic therapy in statins and maybe in aspirin before we go ahead. Okay, we come back to intervention. Placing a stent. What medicated stent do you use? Are Indian medicated stents of any utility at all?
So, unfortunately, I am not biased or anything like that. I use only US FDA approved stents. I've been upfront very this thing. I said I don't want to. I'm sure Indian stents are very good, but the data is still lacking. So that's one thing. So I use 3 stents. One is from Abbott, Boston, Medtronic. Now Terumo has got US FDA approved also. So
what has got?
Terumo.
Okay.
I'm sorry, Biotronic, Orsiro, Biotronic.
Okay.
So these are the 4 stents I use. I'm sure Indian stents are good, but the data is lacking. So, but another thing is the cost is all same. So why not use the best, which is been the
Cost is the same.
Cost is the same.
Indian stents are not cheaper.
Modi bhai ne cost same kar diya sabka. Modi ji has
I
done
thought
that.
Indian stents would still be cheaper even
It
after.
should be. But when the rates fell down, they kept it at 32 all
What
through.
is the average cost of say Zions or any?
32,000.
Is a standard cost.
Standard. If you charge extra, then you lose your license.
Oh,
Even a rupee can't be charged.
Oh, is it? Okay.
Yeah.
And
Some local type, so 32, 33 is fine.
32,000 is good.
So you get the US FDA stent, the number 1 stent like Abbott or Medtronic, this thing at 32. So we tell the patient, this is what it is. And most of them say they use the best one which has got the maximum data. So I'm sure Indian stents will reach there. So they're good. I mean, I've seen them in the workshops and all that. They're quite good. But we don't know the long-term data.
Is there any standardization of cost for cardiologists?
Like what?
Your fees.
Fees, sir, I'm a very proponent. You know, whenever I hear somebody has charged this amount of price, this amount, I get very happy.
Why?
I feel very happy. If those guys who are established start charging peanuts, then we should be doing free of cost. So when I hear a cardiologist has charged 8 lakhs, 7 lakhs, 8 lakhs, I feel very happy. I call him and congratulate him. If Tushar bhai starts charging 500 rupees as his consulting fees, then हम लोग तो free में consulting करना चाहिए. अब Tushar bhai is considered standard. I mean, he has to charge 5,000 rupees, 8,000 rupees as his consulting charges. So that's what.
So what do you charge, for example?
Consulting fees?
No.
For
Angioplasty.
So it depends, like in
For example, the standard twin sharing room.
It depends on hospital like Lilavati and Hinduja and Breach Candy. These are the hospitals where maximum money is being charged by the cardiologist. I think Lilavati and Kharinduja Breach Candy and Kharinduja. They are in the competition. One is in south, one is in north. So a simple twin sharing, the cardiologist fees is anywhere from 2 to 2.5 lakhs.
It is less, he says. It should be more, he says.
In twin sharing, that's the lowest class in Kharinduja. As you go to deluxe, super deluxe and suite, it goes up. So I think 2.5 for a twin sharing is good enough, sir. It should not be more. I mean, then the stand, the other thing. So patient will go with a bill of 6 or something like that.
Yeah.
6 lakhs, 6.5 lakhs.
Okay, where would you do, if we have a poor patient and we want to send them for an angioplasty, where do we send?
Holy Family is there, even Criticare we can accommodate those kind of patients. So it is there, but even Lilavati, for example, if you do a common class patient, the whole angioplasty with 1 stent is 225, which I think is a good deal, is a fair deal for a Lilavati standard.
What is the status in BMC hospitals? Can we send there?
Yes, absolutely. Even my patient I send, because first of all, they are all our friends. We come from there. So we got friends everywhere. Sion, JJ, KM, everywhere. So they have a long waiting list for angioplasty. So whenever you call them, they accommodate our patient and they do. There it is absolutely free. It's absolutely free.
Stents also.
Stents also free. I think I think the same stents, as you said, one generation lower stents are given in 20,000 or something like that over there, but they're Abbott and all that.
Okay.
They're US FDA stents. But they give one generation lower stents, which I think is fair, yeah.
So would you be comfortable, because of course their learning curve, especially the residents who are doing that, or maybe the lecturers, their learning curve has not been.
No, I think angioplasty is done by at least minimum assistant professor, not a
Acha.
lecturer. Lecturer can be sort of washing up with him.
We can.
Yeah. So it's quite reliable.
What is the latest data on multi-vessel stenting versus CABG, and in which situations would you?
So what's happening is unfortunate. The surgeons are suffering in all these areas because that's why you see that MCH seats are getting vacant everywhere. You know, KM has lost the MCH seat, and every hospital is losing their MCH cardiothoracic surgery because bypass is gone from them. Now the valves are going away from them, so they are left with congenital and heart failure surgery. So I think any sensible CVT surgeon should move away from coronaries and valves and think about pediatric and heart failure surgeries. There's a lot of scope in India for heart failure surgeries, including your heart transplants. So multivessel versus angioplasty versus CABG, the debate is over, sir. Unfortunately, the debate is over 5 years back.
Okay.
Stents and bypass surgery have proved the same. In fact, after certain time, the stents do much better. This first 1 year, the stents can create trouble. Restenosis and all those things, stent thrombosis and all those things. In fact, the other way around, the stents long term, this curve goes up like this. Bypass starts with upper curve, but over a period, the graft starts closing down. So it's the other way around. Long term results of bypass, the grafts go down, especially if they use of venous grafts. See, 10% of the venous graft, they close while the chest is being closed. While the patient chest is being closed, 10%. This is data. This is I'm quoting trials. So no surgeon will take this data because they said, oh, surgeon ko nahi aata, ye nahi aata. Because surgeons are in constant denial. They first of all, they denied about stent. Now they have to keep quiet. Now they're denying about valves. Valves are being done by right, left and center now. So it's like that. So it depends if, for example, if there's a distal left main, diffuse triple vessel disease, I would probably not do angioplasty. I would send him for surgery.
Distal
left main, diabetic, diffuse triple vessel disease, LV of 20%. So probably bypass would be my first choice.
Okay, so that is one situation where you will refer for bypass.
Absolutely.
Any other situation where you will insist on CABG and not do, like in diabetics, we said triple vessel.
Our patients are basically, it's money driven. Most of the bypasses go because they cannot afford intravascular imaging, rotablators, multiple stents, cardiologists, huge fees and all that. So these are the patients, we send them for surgery. So stents can go anywhere. I mean, you know, many big guys have got 10 or 12 stents in their body and they're roaming around nicely. So stents can go anywhere. But the point is the affordability plus compliance with the antiplatelet drugs for long term. So most of these patients will start losing blood, they become anemic and all those things. So all those things have to be considered. So I will send this kind of patient for bypass surgery. So we are quite liberal in sending bypass patients. It's not like a hard and fast rule.
What is the maximum number of stents you have heard or placed in a patient?
I have placed 8 stents myself to a patient, but that is in two stage. But there are people who are with 12 stents also.
12.
Yeah.
Wow. Okay. About a little bit about antiplatelet therapy, because all of us have some area of confusion there. After 1 year of, say, dual antiplatelet therapy, after a PCI, if you have to stop one drug, is Clopidogrel the only drug to be stopped, or you can even stop aspirin?
Stop the least powerful one. The least powerful one is ecosprin.
The least powerful is ecosprin.
Ecosprin. So keep Clopidogrel as continue the drug, because US they use 81 milligrams of aspirin because their Plavix, everything is still dictated by the insurance company and it's expensive. Here our Clopidogrel is so cheap. So one drug of Clopidogrel should be continued after 1 year.
What about resistance? Is there documented?
Absolutely. There is the 18% of the patients are resistant to Clopidogrel. That's where ticagrelor came in. And as of now, we have no evidence of ticagrelor resistance. The other good drug is prasugrel. Prasugrel is also very, very good drug, which I use it. But Prasugrel, problem with Prasugrel is you have to load the patients after defining the anatomy. Means you do the angio, there's a LED lesion, now you want to do a stenting. At that time you have to load him on the table. You cannot preload him in the casualty or anywhere else.
Because of bleeding.
Because bleeding and all those things. So Prasugrel doesn't have a trial like ticagrelor or Clopidogrel that you can load him in the emergency department or wherever it is. Prasugrel has to be given after defining the anatomy, 6 tablets, 10 milligrams each, and then he continues 10 milligrams of Prasugrel and 75 of aspirin.
Prasugrel also has a
3 contraindications. It's a black box warning which comes on the cover. One is age more than 75 and previous any stroke of any history, any long duration stroke, and weight less than 60 kgs. Weight. Frail lady or frail gentleman, weight less than 60 kgs. So these are absolute contraindications for Prasugrel. That's where the drug goes down a little bit, at least by 20%. Yeah. Roll off? Calcium score in CT? Yeah. So just a quick this thing. A 0 calcium score, the data now says 0 calcium score, you are immune to atherosclerosis for next 8 to 10 years. Immune.
Wow.
Unless you mess around yourself and start doing all those bad things. So then you're calling for trouble. That's the data. And 50 to 100 or 0 to 100 is again, you have to take in total, the patient symptomatology and all those things. So the more higher the calcium score, the more indication to intervene him. That's how it is. Now the calcium score has become very important because of aortic valve. Now we are doing a TAVI, we are doing transcatheter aortic valve implantation. Their calcium score of more than 1,500 on the aortic valve becomes one of the indication of severity of aortic stenosis. Ideal patients to advise calcium score?
Should it become part of a health checkup after the age of 50?
Calcium score is very safe because first of all, you're not putting a vein, you're not injecting dye, you're not doing all those things. It's just a 5 cardiac cycles, I think so. 5 cardiac cycles, this thing.
Small amount of radiation is the only thing.
Very small amount of radiation, absolutely small. So calcium score can be done routinely. There's no this thing.
I will.
Yeah. Again, I'm telling you the same thing. It depends on the machine and this thing. But in Bombay, it's pretty much standard. It's pretty much. So, for example, the most favorite indication is the patient comes with 7 or 8 minutes stress test positive, and you are not sure about what is it, and the patient himself is not very this thing. So, these are the patients we send them for CT angio. And if something turns out over there, then we call them for angio and this thing.
One area of stress test, treadmill test especially, false positive treadmill tests are not uncommon. In women, of course, fairly common. Sometimes in men, positive stress are seen. So, asymptomatic positive stress test in men, asymptomatic even during the testing, whether instead of doing a catheter angio, even though the ST depression was 2 millimeter downsloping, really positive stress test, can we do a CT angio rather than a catheter?
If it's like a severe positive, we had one of our patient who is a runner. He's very, very fit person. So to renew his insurance, he's 55 or 60 years old. To renew his insurance, he did a stress test which was positive in second minute. Second minute, it was positive. In 2 minutes it was. That's first stage, 3 minutes is each stage. So second minute, the ST started going down, but he was asymptomatic and he went on for 6-7 minutes. The ST depression went down to almost 5 millimeters. For this patient, and asymptomatic, he came out because he's running every day, he's cycling, he's swimming every day. So this patient, I would do an angio. But it will be hard to convince him because he says, I'm doing all these things, why you want to do an angio on me? So we did an angio. And he had a calcified distal left main 80%, total LAD collateralized, total circumflex collateralized. RCA was the only vessel with 80% block giving collaterals everywhere, and he was totally collateralized. You could see the collaterals going like a native circulation. So well the LV was preserved, and LV was 60%. So that's how, these are the surprises which come out.
I'll go back a bit. You said 18% of patients are resistant, become resistant or are resistant to clopidogrel.
18%, 18.
1/8. How do you identify them?
No, it's very difficult. So we had this machine lying in our hospital for research, this thing, where we could take the buccal mucosa and they identify these alleles. This particular allele which was there was resistance, but that test did not get an US FDA approval. So it's very difficult to, for example, if the patient comes with stent thrombosis, let's say for example he comes stent thrombosis within 3 months, probably he's resistant.
So you are saying that 1/5 almost of the patients, you will give single clopidogrel lifelong, while it may not be working.
So it is worked for 1 year. If it's worked for 1 year and he has been event free, then I would have probably continue. Now patients with Brilinta, ticagrelor, so that is another question. If he's on Brilinta and Ecosprin, so we stop Ecosprin and continue with ticagrelor 90 BD. But now the facility is available where you can continue with 60 BD also. 60 BDs, and it's relatively cheaper than that. So single antiplatelet, 60 BD. Maybe for next 3 years, if it's high risk angioplasty, then just put him on simple aspirin if everything goes smoothly for next 2-3 years.
Okay.
So again, sir, if there's calcium, so this patient recently had calcium score of 400. He came from Ahmedabad, Mr. Vipat. His score was 400. And they did a stress test. Stress test also was positive. So I could find only a diagonal which was intermediate size, had an 80% stenosis. And that's about it. So probably the stress test is positive because of the diagonal. And the rest of the arteries were normal. So I kept him on medical therapy and sent him home. So these things are there, borderline situation.
So last topic
one
to
more
discuss.
thing is intravascular imaging. You are asking intravascular imaging.
Correct. So IVUS I want to discuss and aortic TAVI I want to discuss if you can. We'll take that question.
No, he underwent
what did he do for the athlete who had good collateral circulation?
No, he underwent a bypass surgery. There was a lot of denial in his mind. So he underwent a bypass surgery. Dr. Bhattacharya did his bypass surgery. This is a 6-year-old story now. So he's back and running and swimming and all those things. Well, the collateral circulation is not as powerful as the native circulation. Please understand that. Collateral circulation is coming from a different artery. It is not the native artery. So if something happens to that artery over there, all the collaterals will shut down.
Sudden death.
And then you'll have sudden death.
Okay. We spoke about FFR. FFR is a functional investigation. Now we have also anatomical, not physiologic, but anatomical investigations available during cardiac catheterization. The one that is important is called IVUS and the other is OCT. So let us talk about IVUS, intravascular. Is it intravascular ultrasound?
Intravascular ultrasound. So what happens is you have a transducer at the tip of the wire. So you go inside. Angiography is 2-dimensional. So angiography is not 3-dimensional. It's 2-dimensional. So sir may say 50%, I may say 80%. It's all again eyeballing and this thing. So we need to do what intravascular ultrasound does is it studies the vessel in 3-dimensional. It's as if you are going in the vessel. So typical, it's as the name suggests, intravascular ultrasound. So high frequency sounds are bombarded against the vessel wall inside intima. They are received by the transducer as echoes. These are sent back to a console and console will form the image. So you can see the intima, media, adventitia very nicely. So you can make out the lesion, the length, the morphology, the calcium, dissection, red thrombus, white thrombus, all those things you can make out. It's beautiful. Intravascular imaging is so beautiful, and now it was a 20 megahertz catheter probably 15-20 years back. Now we have come to high definition 60 megahertz catheter, which is fantastic. In fact, 2 days back in Hinduja, I did a case with high definition IVUS. Beautiful. I mean, you can know the length of the stent, the diameter. Basically, these are called as precision angioplasty. If you want to be precise, you have to do this. So, for example, left main is generally left main is 4 plus. How can you make out an angio 4 plus? You cannot make out. So you have to take the intravascular ultrasound, get the measurement. For example, other day I was doing one critical care, I was doing one patient.
Please explain 4 plus.
4 millimeters, 4 millimeter vessels. Coronary arteries are in the range of 2.5 to 5 millimeters. The left main is around 3 to 5 millimeter. Proximal LED is 3 to 3.5 millimeter. It keeps on going down in the diameters. So when I say 4 millimeters. So this is the thing. Other day I was doing an angiography of a CEO of a big company. So he had a proximal LED 90%. So they said, go ahead and do the angioplasty. I said, I can't do. I don't know the size. Then somebody
Size
said,
of the vessel.
vessel, big, it's big vessel. I said, I cannot do because whatever size if I put, by guessing, the stent may float inside. I said, I'm not doing this.
So if you put a 3 millimeter stent in a 4 millimeter vessel, we
your
have a problem.
stent has to be properly embedded in the media, not even in the intima, in the media. If you remember your anatomy, intima media adventitia. Adventitia is the deepest layer of the vessel. So your stent has to be embedded in the intima, in the media, so that the restenosis are low. You can't have the stent floating inside, otherwise he'll have a stent thrombosis and he'll present with sudden death. So somebody said, you take the biggest stent and put it and get out. I said, I don't know. I said, if somebody is an expert who can see with an eye better than me, get it done by him. So patient understood. Patient said, nothing, doc, you get the intravascular imaging, do whatever you are suggesting. His vessel was 5 millimeters. His proximal LED was 5 millimeters. I have to order for a special stent because 3.5, 4 are available, 5 is not available. So I had to get a 5 millimeter stent, put it, dilate properly, then I did ultrasound again, the stent was sitting. So what if I had put a 3.5 or 4 millimeter stent in this patient? Within 15 days he would have come with a sudden death. He would have not made to the hospital. These patients will not make. They will die suddenly. Proximal LED, they die suddenly at home.
We have abdominal sonologists. Yeah. And some sonologists are very good.
Yeah.
Some are very bad.
Yeah.
And therefore experience counts.
Correct.
In
In every
interpreting
field, in every
sonography
field,
results.
yeah.
How do you interpret sonography? I was
Correct.
without a great learning curve.
Yeah. So IVUS has got a steep learning curve. That's why it didn't become popular as was expected. Now there is something called as OCT which has come up. Optical Coherence Tomography. Initially this technology was started by the ophthalmologist for seeing the retina. So from there the cardiologist took over. So what is the principles? It has got a lens at the tip of the wire and this gives away infrared light. So here there are no sound waves, they are light waves. These light waves are bombarded against the vessel wall and the catheter comes back and images the entire vessel and these are reconstructed on the console. So to cut the story short, IVUS is a black and white TV and OCT is a high definition color TV, Sony LCD. So people learnt OCT much clearer because it is easy to learn. The images are very, very clear. You can see beautifully the intima, the media, adventitia, and computer does all the calculations. It tells you the lesion, the length, the diameter, the morph, everything computer tells you. You have to be just standing there and reading the thing. It is so advanced now. So OCT has become more popular because the learning curve is much shorter. IVUS is, but there are indications and contraindications for OCT. OCT requires a clearance of blood, so you have to inject contrast. So additional contrast keep on going with every study. So patient with high creatinine, you cannot do an OCT. OCT has got a limitation on big vessel. For example, left main, which is 5 millimeter, OCT cannot penetrate that. So you have to use an IVUS. So there are areas for both the things, and OCT is expensive, IVUS is cheaper. But OCT has got a shorter learning curve, IVUS has got a longer learning curve. So you have to balance. I think once you are an interventional cardiologist, you should be perfect in both.
Okay.
You should be knowing both, you should be knowing everything.
Last.
Specific indication of OCT?
For OCT, yeah.
So,
first of all, just clarify with them that IVUS is not just used before angioplasty, before putting a stent. It is also often used after putting a stent.
both. if you want to study the anatomy, you have to do it before. Because if there's a lot of calcium, then I will change my way of approach. I'll use a rotablator, cutting balloon, all these things. So to study the morphology and after putting a stent, to study the end result, whether when you put a stent, you want to see the edge dissections, whether there is edge dissection, whether stent is expanded or not. So number comes there, 90% expanded. And the stent, you can study a three-dimensional stent study also in that. And it shows areas which are not expanded. So you can go there and expand. So what is an ideal indication for OCT? If you ask me, it's only the cost. If the patient can afford, I do OCTs in every patient. It's only and of course creatinine has to be permissible. OCT catheter is 1 lakh. 1 lakh. Single use. But in Holy Family we use it for 3 times. That's a different story. And what we do is we put 50 to 3 patients. So that's how we cover the cost. In South India, everywhere they use it for 3-4 times. So as long as the lens doesn't get damaged, you can sterilize it properly. You can use. There's no problem.
So now there is Oxford and New York again.
Oxford and New York. But we tell the patient, this is a used catheter, but it is sterilized 3 times. So most of the patients do agree and nothing happens.
So they have a code word in the cath lab. Oxford is old catheter to be reused.
This is for the patient not to understand.
And,
and
New York
technician.
is new catheter.
Oxford, Oxford technician understand. Used to. New York. So the patient doesn't understand. Oxford, New York. Huh? Yeah, Oxford and New York. Then patient was.
Okay, last we have 5 minutes, sir.
Yeah.
Introduce us to TAVI. Indications. Aortic stenosis, as you all know, aortic stenosis, if it is significant, symptomatic, if you don't operate, the patient dies. Dyspnea, angina, syncope, 3 exertional symptoms. If the patient has or a certain gradient on the Doppler echo, patient has to be operated, otherwise the patient dies. There are 2 options. One is aortic valve replacement and the second is TAVI or TAVR as they call it. Tell us about TAVR.
TAVI and TAVR are basically transcatheter aortic valve replacement or implantation. So this is another field where the cardiologists have taken over from the surgeon. So earlier the indications were compassionate grounds, old people, comorbids and all those things. But now the indications have diluted. Now very soon, next few years, it will come as the patient choice. If the patient says, I'm 50, I still want a TAVI, so you have to go ahead and do it. So how it is done? It is done like angioplasty through groin. And the valve is there mounted on a balloon. It goes all the way. It crosses the aortic valve and you inflate it and the valve stays there and the balloon, everything comes out. So it's like that. It's expensive, but recently the world celebrated 20 years of TAVR, but in India from last 6-7 years it's become very popular. The whole country does about 500 plus TAVRs every month.
India?
In India,
yeah. Wow.
Yeah. So the numbers are growing. It's expensive. TAVR will cost you anywhere between 25 to 30 lakhs for the FDA approved, US FDA approved valve. But there's an Indian valve which can be done in the range of 15 to 16 lakhs. So I've been using Indian valves for this because the cost is prohibitory.
How many cardiologists do TAVR in Mumbai?
Oh, now most of them are getting trained or certified. I myself have assisted in more than 30 TAVRs. Individually I've done 5. So I'm not yet certified, but another 1 case of TAVR, I'll be certified at least by 1 company. So it's not as complex as doing an angioplasty because TAVR is done entirely, the planning is done entirely on CT based. Your valve size, your implantation angles, your vessels, aorta, iliacs, everything is, the company comes with a full pack of that valve size. You are not going inside and deciding which valve to put and all that. Everything is pre-decided. The whole thing pre-decided. You have to just mount the valve, go deploy it. Of course, there are several complications like stroke, complete heart block and all those things, which is in surgical also. But one thing I want to tell you the difference between a TAVR and a SAVR. SAVR is surgical. The effective area, what you get through a transcatheter is much more larger than surgical valve.
Oh, is it?
Yeah. Effective orifice, ERO, what we call it as, is much better on TAVR than SAVR. The surgeons will never agree it. So don't believe the surgeons. They are in complete denial mode. There was a surgeon 8 years back when TAVR came to India. He wrote a huge blog saying this is a humbug, this is duping patients of their money and all those things, that same surgeon is learning TAVR now. He started learning TAVR. So it is a teamwork. So the surgeons keep on denying and we keep on giving evidence. They keep on saying no, no, no. Finally they say, chalo bhai saath mein karte. Tera aadha, mera aadha, chalna.
So you said the company fellows come. Do they also come with an expert in TAVR to accompany you?
No, company will. So there are proctors, what we call an expert proctors, who run around all over the country. So the proctors come. Earlier we had like 4 or 5 proctors. Now every city has got 2 3 proctors. At least the big cities.
Proctors are coming from abroad or
No, national proctors now. When we started 7 8 years back, we used to get people from Budapest and Europe and all that. But now there are so many national proctors, so many North and South Indians, and so many are there.
Mumbai-based proctors, can you name some?
Mumbai-based proctors are Maulik is there, HN mein, Maulik Parekh, Maulik is there, Harish is there, I am there, and we have formed, me and Ravindra Rao, we have formed a team. Ravindra Rao is one of the highest TAVR operator in the country. He's from Jaipur. So Ravindra Singh Rao and myself, in fact Ravindra Singh has made proctors to all of these guys.
Oh.
So Ravindra and me, we have formed a team at Lilavati and we do TAVRs together. We have done almost 25 TAVRs over there and every Friday comes. So we both are a team and we keep on doing. Last Friday we did a TAVR in a 92-year-old gentleman at Mr. Tandon at Holy Family. So it's going on, the program is active.
Often these patients are elderly because atherosclerotic aortic stenosis, calcific aortic stenosis is the commonest cause, and often they have triple vessel disease. So before we decide on the aortic valve approach, we will do an angiogram to see the coronary arteries. What will happen if there is triple vessel disease significant with aortic stenosis?
If the same Mr. Tandon had a LAD calcified and the circumflex calcified, he was 90 plus. So what we did was we admitted him on Monday. Tuesday I did a rotablator of the LAD and circumflex, put 2 stents over there, and that was very good. We did under imaging, so that was nice. And then Friday we got a TAVR done. And this is Sunday, so tomorrow most probably he'll go home. He's already walking in the room.
So you have kind of cheated the surgeon in 1 week.
Yeah, it's again the cost is a big issue. See, surgical valve, surgical replacement, any of the big surgeons, it is around 10 to 15 lakhs.
Yeah.
It's 10 lakhs because the valve itself costs 2.5 lakhs. In 3 lakhs is the valve charges. Surgeon will charge 3 lakhs, hospital, so it will be 10 lakhs. So if you put an Indian valve, 15, 16 lakhs, I think if the patient is affording, I think it's 2 days of staying, no cutting, nothing. He goes home walking. I think it's a great advantage.
Wow, that's nice. I think we can. PAMI, I forgot.
Triple vessel disease?
Sorry.
I'll answer your question. I'll answer your question. So there's no scrutiny in our country. Like how we don't have scrutiny for the cath labs. Anybody, anywhere in the cath lab doing so many things, we see the complications coming from all these hospitals. It's hardening. So America has formed a thing called as AUC criteria, AUC, Appropriate Usage Criteria. Today in US, you have to prove the stenosis is significant. If you do the angioplasty without going through the Auc criteria, your dean will call you and will fire you. Maybe he'll take you away from this. So that's why the number of angioplasties in the US have gone down by 25%. Mount Sinai, where Samin Sharma is there, their numbers have gone down because now, see, 50, 60%, anything they have to put a stent without asking because everything is covered by the insurance. So now they have to prove that this is significant and document it, then go ahead and do it. Otherwise, it's very strict. So we don't have a scrutiny committee in our country, Rajesh. Yeah. Compassionate ground. So bicuspids, we have 18% incidence of bicuspid in Southeast Asia compared to 2% in US and Europe. So bicuspids are very, very high in our country. Bicuspid is very difficult to operate because the aorta is also diseased. The ascending aorta also is diseased. Valve is very narrow. The orifice is 18 millimeters, 19, 20. So bicuspid 60, 58 we have done. Because that is one indication. They say that you can do it in a younger patient because the surgical risks are very high. Otherwise, a tri-leaflet aortic valve, 60. Other day I got a patient at 65. I told them I will not do TIVI for you. They came with the intention of TIVI. I said I will not do TIVI because you are young. You go surgical, your valve will last for 15 years. Then we can do a valve in valve. We can do a TIVI at that time.
How long does a TAVI last?
So the 10-year data has come. The 10-year data was 20 years of TAVR we celebrated 1 week back. So they presented 10-year data now. 10-year data, I'm telling you openly over here, it is much better than surgical results.
Yeah.
Much, much better, the surgical results.
Okay, the lunch is ready, so we'll take 5 minutes.
Yeah, 18%, I told you.
18%, not more, but
Bicuspid is a very huge number. Rajesh is my good friend, so he'll always have this argument with me. No. See, that's why surgeons have to now evolve. There's enough heart failure patients. They have to now assist devices, mitral valve repairs for MR, dilated cardiomyopathy, LV assist device, heart transplant. They have to look for those directions now. If they think, see, mitral valve is also going to come now. Now for TR, tricuspid regurgitation, there's a valve called as Pascal, which is already released in the US. So all the valves will be, congenital valves are being taken over. Melody valve is there for aortic stenosis, pulmonary stenosis in pediatric age group. So valves are taken over by the cardiologists. So they have to themselves evolve into something very, very innovative.
I'll take 5 minutes on PiE. One of the greatest indications of angioplasty is PiE.
It's the only thing which has shown to reduce the mortality, PiE. The only procedure where PiE says reduction in mortality.
Primary angioplasty for myocardial infarction. If they encounter a patient at home calling them that they have severe pain and they think that the pain is cardiac and they do an ECG and the ECG shows an anterior wall infarction and they can send the patient to a local nursing home for thrombolysis or they can send them to an institution for PiE and obviously PiE is better than thrombolysis, that has been proven without any doubt. So should any patient go to any local ICU at all or no?
So if your center, the FMC, the first medical contact is 3 hours away from the primary, the area where you can do the angioplasty, if it's 3 hours away, then better to thrombolize the patient. If it's less than 180 minutes, I think 120 minutes, less than 120 minutes, it's worth taking the risk and transporting the patients. So nursing homes and primary care will still do good because there's something called as pharmaco-invasive therapy, which Dr. Shah will tell you. Both. That is thrombolysis, you give the thrombolysis, stabilize the patient and shift him. So you are reducing the risk of transport-related problems. So you're opening the artery and then sending him for doing
in the West, they do a thrombolysis in the ambulance itself.
Ambulance itself.
And then they send it to the tertiary center, maybe for a PiE. That they call it pharmaco-invasive, a combination or a hybrid procedure in that sense. As a family physician, they get an acute myocardial infarction at home, they see one, they have been told that give them aspirin 325 milligram, clopidogrel loading dose of maybe 300 milligram statin. What should they do? What should they do?
So, Clexane is another thing. You can give low molecular weight heparin. No problem. You can load him with aspirin, clopidogrel. Give him 60 milligrams of Clexane, subcut or whatever you have. So, at least these 3 medications will lower the mortality, immediate mortality for more than 40-50%.
Wow.
So, this is very important. Then you can transfer him either if you think center is very far off, then at least send him to a center where he can get a thrombolysis done. See, the first 30 minutes, if the patient presents, thrombolysis and primary angioplasty both are equal.
First 30 minutes.
First 30 minutes. But that is very difficult to get because he has to get the symptoms and he has to realize and come fast and all that. But not doing anything is worse. So at least try and get him a thrombolysis done. And nowadays with tenetiplase and retiplase and all these beautiful drugs, your chances of recanalization is almost 80-90%.
They give aspirin, clopidogrel. Just a second. They give aspirin, clopidogrel, and we have now been told that before PAMI.
Statin has to be given 80 milligrams or 40, whatever, the high dose. For medicine. High intensity statin has to be given. I forgot about that. You can give that.
Brilinta, itacagrelor, is preferred over clopidogrel.
Yes.
So,
If you have an ST elevation MI, if you have confirmed or with your physician or cardiologist, load him 2 tablets of Brilinta, no problem.
So instead of loading with clopidogrel and aspirin, load with 325 aspirin and 180 milligram of Brilinta, ticagrelor, and the statin.
Statin, and that's it. Yeah. And Clexane. Clexane.
Yeah. Typically, I think in the hospital when they come to us, we give IV Clexane partly and subcutaneous partly, 20 IV.
But here if you're treating in a home environment, just give him subcutaneous. Just, you have to start moving the patient by doing this. Yeah. If you have an ST elevation, yes, absolutely. No, sir, no. No. So, PAMI basically is ST elevated MI. So, ST elevated MI always has a mixed kind of thrombus which is there. So, those IV antiplatelets you're talking about like abscessimab and all that are given away because Brilinta and all those drugs are so powerful. With these new antiplatelet drugs, you don't have to worry about all those things. Yes. Yeah, absolutely. Yeah.
I think that was a brilliant lecture. So I'll thank you so much to learn a small thing from us, Anand. Congratulations. Thank you so much. Please have lunch. Lunch is served and we shall meet exactly in 45 minutes.